one of what you'll consider to be a more boring topic. So integrative medicine, for those of you who don't know, is basically a continuation of the health enhancement program. So of all the, you know, like all the stats you have to remember and make up like maybe a few questions in the exam. But the first lecture that you'll have, which is one I'll be giving an overview of, probably contains the most information that will be assessed in the exam. So if you're going to study for one of them, this is probably the one. But yeah, so it's just a collection of just different facts and stats. So this week's lecture is called Evidence of Integrative Medicine, and it's all about complementary and alternative medicines, basically CAMs. So I guess the first takeaway is that CAMs in general, especially in media, are represented quite positively. So in a study of women's magazines, 81% of all CAMs were presented in a positive light, 16% in a neutral light, and only 2% in a negative light. So make of that what you will. And there is a very heavy skew towards promotion. So it's up to you to determine, are these CAMs actually that beneficial? So there's also the different levels of evidence-based medicine, which is important for evaluating CAMs. So it goes in order of where the lower the level, the more, I guess, the more effective it is. So level 1 is the highest, where it's a systematic review of RCTs. Level 2 is evidence from at least one RCT. Level 3 is a non-randomized controlled trial, just to one of those. And level 4 is everything else. So all the other studies, and especially consensus opinion, which is the lowest. So someone saying on TV that something is something. And this was a table that we were shown by Craig Hassard, and it's a table of how frequently GPs use CAMs in Australia. And I believe we were recommended to just keep an eye on the most common ones. So I've highlighted the 4 that are most common. And I noticed that between referral and practicing, the top 3, or 3 of the top 4 are in common. So that's acupuncture, meditation, and hypnosis. So if you remember those 3, you've remembered 6, I guess. And the only thing that's different is chiropractors are referred more, and vitamin therapy is practiced more. So just remember that difference, and you've got all 8. And a bit more background on just claims being made by senior doctors. So it's a bit of a startling, I guess, finding where half the statements made by senior doctors in hospital meetings were actually like false or just refuted by evidence. 1/6 of these statements, there wasn't enough evidence to back it up, so you could go either way, and only 1/3 of the statements were actually correct or supported by evidence. And statements are often given with great conviction, and because of the seniority of the doctors, they're generally accepted by young doctors as just fact. And doctors, particularly older ones, weren't responsive to feedback regarding evidence. So yeah. And also in our lecture, Craig Hassard touched on what causes anti-vax beliefs. So this is probably quite relevant in the current day and age. But I think the order you should probably remember, this can easily be assessed, but in order of what's most causes these beliefs, number 1 is conspiratorial thinking. So I guess like organizations planning stuff, you know, big pharma and stuff like that. Number 2 is reactance. So a low tolerance towards impingements on freedoms. Number 3 is disgust towards blood and needles, so fear of injections, things like that. And the 4th one is just people who have individualistic or hierarchical worldviews. So kind of how much control should society have over individuals, or are hierarchies desirable? Yeah, and that's a typo, so ignore that. And a few specific complementary and alternative medicines were also touched upon. So the first one was glucosamine, which is an amino sugar and protein lipid precursor, and its effects on CVD, so cardiovascular disease. So after adjustment, glucosamine use was associated with significantly lower risk of, firstly, cardiovascular death. So this is I guess, the most significant one because it has a 0.78 hazard ratio. The lower the hazard ratio, the more, I guess, the more effective or beneficial the treatment is. A 1 hazard ratio means it has no effect. More than 1 means it actually does more harm than good. CHD 0.82, hazard ratio, cardiovascular disease events 0.85, and stroke 0.91. I'm not sure if I don't think you really need to remember these numbers specifically, but perhaps remember the order, because they can ask questions like, of the following, what's the most effective against, or what's the most or the least effective of the 4, A, B, C, D. As for Iscador, I'm not sure if I'm pronouncing that right, but it's a fermented mistletoe extract in cancer, and the overall hazard ratio was 0.59 in favor of this treatment, which is quite significant. And the greatest effect was on cervical cancer, which is more than half reduction in hazard. And the least effect, but still effective, was lung cancer with a 0.84 hazard ratio. I probably don't need to remember the numbers once again, just remember that the greatest effect was on cervical cancer and least was on lung cancer. And I believe this was touched upon before in first year, but on the topic of religion is generally beneficial for health, particularly depression. However, when taken to the extreme, so extrinsic religious orientation and negative religious coping, so for example, avoiding difficulties by attributing them to religion, can take things the opposite direction. And this was a statement that was left at the very end of our lecture, which was, in conclusion, you need to keep an open mind for things such as complementary and alternative medicines, but not so open that your brain falls out. So I just thought that was a pretty interesting statement to just have in the back of your head. And also present in the lecture, I believe, were just a bunch of therapies and just like whether they were useful or not. So I've summarized them in 2 sets of tables. So red just means it's not useful. And if you just look at them, they don't seem that useful. So like Vega machines, iridology, don't know about them. Yellow, it's either useful or evidence is being reviewed, or there is still a bit of debate. And green is just there is evidence that they are effective. So I've bolded the ones that seem to come up a lot in previous exams. So all about pain management. So like, which of the following isn't effective for pain management, which of the following is. So remember these 5. Also at the bottom are some anti-cancer therapies. So like herbal medicines and turmeric. Those have anti-cancer potential, and it is worth keeping them in mind. And also green tea, that one's quite a big one. And on the second page, just a continuation of the table because it couldn't fit in one slide. But just once again, I've bolded anxiety. So these ones are also important because often in a question where they ask you which of the following is effective for depression, they'll have, say, 4 answer options, and 3 of them will be for anxiety, 1 will be for depression, or vice versa. So you do need to differentiate between them. Anxiety, the things that are effective for anxiety, as you can see, aren't the same as the ones that are effective for depression. So do keep those in mind. And there are another few ones that are effective for depression. So there's bright light therapy and SAME, which I don't actually remember off the top of my head, but it's also another therapy. But that actually concludes the end of my slides. It's not much detail. Just, I guess, try your best to remember as many therapies as you can. If you can't, it's okay. It's only a few questions at most on the exam. But yeah, happy studying.
All right, I'll take over from here. Okay, can everyone see my slides? Cool, thank you. All right, so now we're going to go through resp anatomy. And I think we'll go through physiology and everything later. But before we get stuck into like our main organ, which is the lungs, thought we should go through the pleura first, which honestly took me a little while to get my head around. But basically, the pleura is I think they described it as like a piece of glad wrap kind of folded on itself, but it basically lines the lungs and the body wall, which your lungs are sitting in. But one important thing is that even though it folds on top of itself, so it kind of looks like 2 layers, it's actually one continuous layer. And it's made of simple squamous cells. supported by connective tissue. And it falls into these two layers at the lung hilum, which is basically where all the structures enter your lungs. So your arteries, veins, your bronchi, that's where they enter. And this part is called the pulmonary ligament, and I'll show you a better picture later. But the two layers are your visceral and parietal pleura. So the visceral lines the surface of the lung itself, and the parietal pleura lines the chest wall. So you can see the two layers here. And between the two layers, you have a pleural space, which is a potential space. And in there, you have serous fluid. So we'll go to, yeah, there we go. A potential space is basically a space which isn't supposed to have anything in it, except for the serous fluid. But what happens is you can get pathologies when you get things that are not supposed to be in there. So if you get air in the pleural cavity, this causes the pneumothorax. Blood, it's called a hemothorax, and fluid is called a pleural effusion. And I think we'll go through those later on as well. So this serous fluid that's inside the pleural space has two functions. So it lubricates the pleura, and which allows them to slide over each other when you breathe and your lungs expand. Because if they don't, what would happen is your lungs will be restricted from expanding. And it also provides surface tension. So it keeps them two together. And this allows for your lungs to expand at the same time as your thoracic wall, because if you remember, one lines the lungs and one lines the thoracic wall. So it kind of connects them and makes sure everything goes in and out in a coordinated way. And an example here is the pleural effusion we're talking about, where you get fluid between the two layers of the pleura. And you can see this big bulge of fluid there. All right, so your parietal pleura, which is the outer part, has four parts to it. Your costal, mediastinal, diaphragmatic, and cervical. I'm not going to read through all of this, but the main things to note is the innervation of the pleura. So your visceral pleura inside doesn't have the same kind of pain sensation as the parietal pleura, which we'll go over. But if you get irritation of any of these parts of the pleura, it's important to know how they would present. So the costal pleura, I think I have a picture on later on, but this is like the outside here. And that kind of pain would radiate to the chest and present as the chest pain. And the mediastinum, which is in the middle, this is innervated by the phrenic nerve. So if you guys remember C3, C4, C5, keeps the diaphragm alive. So that kind of diaphragm pain radiates to the jaw or the shoulder, kind of like a heart attack. There's your diaphragmatic part as well, which is also the phrenic nerve. But the middle of the diaphragm, the diaphragmatic part is innervated by the phrenic nerve, but the sides are innervated by the intercostal nerves. So same thing as the costal. So your pain radiation will be the same as those. And your cervical is your T1 nerve. So this will go towards the medial side of the arm, if you guys remember your dermatomes. And important to note that it's thicker than the visceral pleura, and the blood supply is from the intercostal arteries. And your visceral pleura, the important thing to note here is that it's not sensitive to pain, temperature, or touch, and it can only detect stretch, and it's innervated by autonomic nerves and supplied by the bronchial arteries. Here you can see the different parts of the pleura. So your costal pleura is here, and your diaphragmatic goes along the diaphragm, and the mediastinal goes along the middle there, and your cervical pleura is just at the top here. So it's a good image to refer back to because it kind of shows how the pleura is formed as well. Okay, so you've got also pleural recesses, which is parts of the pleural cavity that are not completely filled by the lungs. So they're kind of open space, not open, but there are spaces here. You have two, so you've got your costophrenic or costodiaphragmatic, which is these parts here. And then you have the costomediastinal, which is in the middle there, your mediastinum being the middle part there. And the important thing here is that fluid can collect here. And if you look in a chest x-ray, there's a specific sign you can look for, which is blunting of the costophrenic angles, which is when these angles here aren't super sharp. And that is because you have fluid accumulating in this like costodiaphragmatic or costophrenic recess. So it's just important to know that these exist, really. And pleural reflections aren't super high yield, but they're basically areas of the pleura changes directions and it forms a fold. Yeah, okay. Now this part as well, I think we've been tested on a couple of times. So your lung surface landmarks, which is basically areas that you can tell from the outside of the body where your lungs reach up to. Anteriorly, your lungs will extend to the T6 level, and laterally T10, and they're a bit lower at the back. So they go to laterally T8, and then at the back T10. And obviously your parietal pleura is on the outside of the lungs, so it will extend a bit more than your lungs itself. And they go 2 spinal levels below the lungs themselves. And you can see according to where in the body wall you are, the lungs are a bit lower as you go down. So mid-clavicular line being the middle of the clavicle, mid-axillary being about here, and mid-scapular being a bit further back. Cool. So that's all for the pleura. Jumping straight into the lungs. Sorry if we're going a bit fast, but there is a lot of content. Any questions, just message in the chat as we go along. So your lungs, basically you have 2 lungs, we all know that. And then the left has 2 lobes, the right has 3 lobes. And the things that separate the lobes of the lungs are called your fissures. So the left, there's 1 oblique fissure, and the right, you have 2 fissures. You've got a horizontal and an oblique one. The clinical relevance of these is, I guess one relevance would be, you can't really see them on a chest x-ray when you take it, but if a patient has the pleural effusions that we were talking about before, sometimes it can be so bad that the fluid goes into the fissures and then you can see a line light up in the pleural effusion. The left lung is a bit narrower and longer because you have this cardiac notch, because your heart's on the left side and the lungs kind of have to move to accommodate the big bulge of the left ventricle. And your right lung is a bit shorter and wider because the liver is in the lung and it's kind of pressing up and squishing the lung from below. Cool. Your main function of your lungs is to oxygenate your blood by bringing air closer to the venous blood and the circulation in the pulmonary capillaries. We know where they're located on either side of the mediastinum, and they're suspended from the mediastinum by the lung hilum that we were talking about before. That's a basic general structure of the lungs. The lung hilar, a lot of questions on these, but basically it's the part where all your vasculature and your airways enter the lungs from the middle here. And it's also where your visceral and parietal pleura meet to form the pulmonary ligament. And if you can see this little, annotate, you can see this little ligament that's here, that's your pulmonary ligament. Okay. Clear that. All right. So your right hilum, it's important to remember where the structures sit relative to each other. Though you guys will see this over and over again in your specimens classes. But in the right lung, you've got your main bronchus at the very back, your pulmonary veins at the bottom, and your pulmonary arteries anteriorly. Left, you've got your main bronchus at the back as well, and then you've got superiorly your pulmonary artery and anterior-inferiorly your pulmonary veins. That's another way to, I guess, I've just spread out the structures so you can visualize them maybe a little bit better, but another diagram if you guys need it. All right, this is a lot of information on one side, but basically your trachea, as it goes down, splits up into your left and right main bronchi, and past there, think of it as like a tree which has lots of little branches. And each segment of the branches we call a part of the tracheobronchial tree. So the purple parts are your main bronchi. And important thing to note here is that the right main bronchus is wider and it's also more vertical and shorter. Okay, the important thing to note there, we'll go through this later, is that because it's more vertical, if you put something into your trachea that you shouldn't have in there, like food, it's most likely to go down the right side than the left side because it's vertical, and it's shorter and wider, so there's more space for it to go through. On the left, it passes inferior to the aortic arch and anterior to the esophagus and the aorta. You've got your lobar bronchi, your segmental bronchi, your conducting bronchioles. They have the greatest airway resistance. So if you get a question on which part of the tracheobronchial tree has the most airway resistance, it's your conducting ones. And your terminal bronchioles, important thing there is that there are no cartilage in the walls. And this is the end of the conducting zone, which is basically an area that conducts air without exchanging it. And then where the gas exchange really starts is your respiratory bronchioles. And this is where your respiratory zone starts, and this has the least airway resistance. And then you go onto your alveolar ducts in the sacs and the alveoli. Yeah, so aspiration of the foreign objects, super important. As we said before, the objects are more likely to enter the right bronchus because it's wider, shorter, and more vertical. Now, depending on the position you're in when you aspirate the objects, they will go to a different lobe of the lung. So if you're lying flat on your back, it's more likely to go into the superior segment of the right inferior lobe, right here, or the inferior lobe, or the right upper lobe. Just think of it as you're lying back. So it's not going to go too inferiorly, but it will still be there. If you're lying on your right side, it's more likely to go to the posterior segment of the right upper lobe, which is there. And if you're lying erect or standing up, it's more likely to go inferiorly because gravity, and it's more likely to go to the back, so the posterior basal segment of the right inferior lobe. Would probably recommend learning all of these. Now your alveoli is where the actual gas exchange happens. You've got your simple squamous epithelium there, and you've got these two cell types there. So the type 1 pneumocyte is where the actual gas exchange happens, and your type 2 secretes a substance called the surfactant, which basically functions to reduce surface tension, and it allows the lungs to not collapse. Yeah, so this is kind of a histological image of the layers that your air goes through to get to your blood. So basically when it enters, it first encounters the type 2 pneumocytes, which secrete the surfactant, and then it meets your type 1 cells where the gas exchange happens, and then goes from there to the basement membrane and the endothelium of the blood vessels, and goes to the plasma and then the red blood cells. Cool. Vasculature of the lungs, not the most high yield, but good to know, I guess. You've got your pulmonary arteries, which supply each lung with the deoxygenated blood. So the lung and the pulmonary circulation is different to your systemic circulation, if you remember. So the deoxygenated blood is what is being taken to the lungs through the arteries. And your pulmonary trunk, important to note that it bifurcates into your left and right at the angle of T4, T5, your sternal angle, into your right and left pulmonary arteries. Then it goes into your lobar arteries and your segmental arteries and your bronchial arteries. These supply your lung roots specifically and the visceral pleura. You've got 2 on the left and 1 on the right, and the 2 arise from the thoracic aorta, and the right one arises from the aorta. Okay, pulmonary veins take blood to the heart So it takes your oxygenated blood to the heart. You have 2 inferior and 2 superior pulmonary veins. Innervation of the lungs is mostly from the pulmonary plexus, which makes sense, pulmonary. And this plexus is around the lung roots, so the lung hilar. The parasympathetic fibers function to bronchoconstrict and vasodilate the pulmonary vessels, and also secrete substances. Presynaptic fibers come from the vagus nerve and synapse in this pulmonary plexus that we were talking about. Sympathetic is located in what's called the paravertebral sympathetic ganglia, which you guys will probably have a look at when you get to neuro, and stimulate relaxation of bronchial smooth muscle, because when you're fighting, when you're running away, you need to get more air into you. It also vasoconstricts your pulmonary vessels and inhibits type 2 pneumocyte secretion. You've also got visceral afferent fibers, not super high yield, but yeah. And then the innervation of the parietal pleura, go back to the slide. I don't think slide 6 is accurate, but we'll change that. But go back to the slide where we had all the different innervations and where the pain would radiate. Okay, lymphatic drainage. There's a lot of lymph nodes around your lungs. Your visceral pleura is drained by the superficial subpleural lymphatic plexus, and it goes into the bronchopulmonary lymph nodes. So bronchopulmonary lymph nodes are here, so just around your bronchi, which makes sense. Then your parietal pleura drains into the lymph nodes of the thoracic wall, because your parietal pleura is lining your thoracic wall. Not the most high yield, but you've got this pathway of lymph flow, and ultimately the lymph drains into your venous system. So you start with your deep plexus lymph nodes, which is the most close to your alveoli, and then goes into your intrinsic pulmonary, bronchopulmonary near the hilum, tracheobronchial nodes, and then your paratracheal nodes. Yep, and you keep going like that. The right side drains into the thoracic duct, which is here, and the left side drains into the right lymphatic duct. All right, the mediastinum. So we discussed before that the lungs lie on either side of the mediastinum. The most important thing for you to remember is the sternal angle in the mediastinum. If you guys feel on yourself and go down a little bit, you can feel a little notch around here, and that's your sternal angle. And the important structures that lie here, you can remember with the pneumonic rat plant. So that's the level of your rib 2 and the arch of the aorta, so where your arch begins. You've got your tracheal bifurcation, which is also called the carina. So that angle where your trachea bifurcates, that's what we call the carina. You have your pulmonary trunk, ligamentum arteriosum, and your left recurrent laryngeal nerve. They both start with L. Where your azygos vein drains into the superior vena cava. You have a bunch of nerves and your thoracic duct. I think the nerves are in the speaker notes. So if you guys want to have a look in more detail later, they're there. Your neurovascular bundle. This becomes important when you want to drain things like the pleural effusion, and you need to stick a needle into between the ribs or into the pleural space to get rid of it. So the order that these structures go through, so you've in every intercostal space, you've got 2 veins, 2 arteries, and 2 nerves. So from top to bottom, you've got your van nav. So vein, artery, nerve, nerve, artery, vein. So the bottom ones are collateral branches, so they're not as big and not as important as the top ones. And the clinical relevance of this is when you're inserting a needle into the intercostal space to drain fluid or air, you should always aim towards the more inferior part, because you don't want to damage these structures up here. So the procedure is called a thoracentesis or a pericardiocentesis, and you should insert the needle just superior to the rib below the effusion, because your neurovascular bundle is located inferior to this rib, if that makes sense. Yeah, that did make sense to me at the start. So read over it again as many times as you want. And this bundle is found between the internal intercostals and the innermost intercostal muscles. Cool. And you've got a whole bunch of arteries and veins and nerves that go through your mediastinum. Important ones being your aorta and its various branches, and then your internal thoracic artery, your intercostal arteries, which we looked at before, and your subcostal artery. You've got your SVC, IVC, and this whole azygous venous system there as well, and a whole bunch of other veins, your intercostals, your internal thoracic, that goes with your artery. Yeah, a little bit of a summary here. It's kind of hard to memorize them straight away by looking at it, but important to know just where your big ones are to start with. And then as you go into more specimens classes and look at more radiology images, you can kind of see how they're related to each other and where they sit in relation to your heart, your lungs, the aorta, and that's probably the best way to learn them. And then seeing how many you can label in your classes and things like that. Because a lot of anatomy you do learn by learning the relationships. Your aortic arch, very important to know its branches. So you've got your arch, obviously. And then you've got a brachiocephalic artery that comes on the right or the left? I think that's the right. That's right. And that splits into your right subclavian and your right common carotid. On the left side, you don't have this brachiocephalic artery before they divide into the common carotid and the left subclavian. Yep, you've got your intercostal arteries. So your anterior intercostal arteries mostly come from your subclavian artery and then your internal thoracic artery, whereas your posterior ones come from your aorta and your subcostal arteries. But important to note, your first and second posterior intercostals come from your supreme intercostal artery, which is also a branch of the subclavian artery. But everything else is from your posterior intercostal and your subcostal. Yeah, important to note also that they anastomose with each other. So there's lots of blood supply within your rib cage. And the internal thoracic artery can be used as a graft if you have a blocked artery in your heart, because this blood supply is not disturbed because you have a whole bunch of arteries. You've got the posterior intercostal branches that are anastomosing, and then they will take over the blood supply there. Cool. Just another image of your intercostal arteries here. And then you've got your intercostal veins. So you've got this whole azygous venous system here. Basically, important to note is your accessory hemiazygous and your hemiazygous drain into your azygous vein, which ultimately then drains into your SVC. That's all I would remember, but the rest is there as well. And a picture for you guys to have a look at. It's always a lot easier to just picture where everything goes. Innervation of the mediastinum is via your phrenic nerve, vagus nerve, and intercostal nerve. A lot of these you guys would have met last year. So your phrenic nerve innervates your diaphragm and the pericardium. We love this little jingle. It runs over the heart and exits the thorax by the inferior vena cava hiatus, which is at the T8 level, and it has a motor and sensory supply. You've got your vagus nerve, which is a very big nerve. You would have heard that it's called the vagus nerve because vagus means wonder and it goes everywhere in your body. So it's actually a cranial nerve. So it's a nerve that's associated with your cranium, your brain. It's got parasympathetic innervation to your heart. It exits the thorax through your esophageal hiatus, T10, and it's got a couple branches. So your recurrent laryngeal one is pretty important. And this one, the right one hooks under the right subclavian artery, and your left one passes under the arch of the aorta. And these innervate your muscles of the larynx, which is your voice box. So if this nerve is damaged, it causes a hoarse voice. So it's a pretty buzzwordy sign to remember. And then you've also got your pharyngeal branches. So all of these kind of innervate things more up in your head and neck region rather than your thorax. Just this is how your mediastinum is divided. Got your superior and then your inferior is divided into anterior, middle, and posterior. Very useful to learn the kind of structures that run through it. And your heart is situated in the middle one. And yeah, the middle is basically made up of your heart, and posterior is behind the heart, anterior is in front of the heart. So your whole inferior is kind of in relation to the heart. And then superiorly, you've got your big vessels, your thymus, vagus and phrenic nerves, and your trachea / your esophagus. Cool. And I'm not going to go through everything in the histology, but important points to remember in terms of differentiating your bronchus and your bronchiole is that your bronchus has this thick hyaline cartilage, and you can see that here. This is what basically helps to keep your airways open, and your bronchioles don't. They don't have the hyaline cartilage, which makes sense. You've got, so this I brought, if you guys know PS Puffer, very good PSB that we had. It's kind of an annotated image that they had of other parts of your respiratory tract. You've got your different types of pneumocytes. Don't really need to know all of these, but if you have a histology session, you will go through all these little parts of the cells. Might do a quick quiz here maybe. Can anyone tell me which of these cells secretes the surfactant? You can type in the chat or you can unmute. Right, got some direct messages. Yep, it's your type 2 pneumocyte. Bit on the respiratory epithelium as well. You've got goblet cells there which secrete mucus. And columnar cells. You've got your cilia that helps to move any dust, any bacteria, anything like that back up. That's why you cough up something. Yeah, more in your trachea, you've got more hyaline cartilage, a lot more histology images for you guys to have a look at later in your own time. But yes, that's all for anatomy. Any questions, just send them through in the chat. And I think we're gonna go through physiology.
Thanks so much, Lakni. That was really great. So I'm just going to send Alan the link to the meeting. Yeah, that was great. That was really, I learned a lot too. We did have a question about chest drains in regards to where you put them in a pleural effusion. And in the message, I just said you put it in the pleural cavity to drain the fluid in that area.
Yeah.
Do you have anything else?
No, yeah, the needle should go as deep as the pleural cavity. So you can actually access the fluid or whatever's in there. And then in terms of where on the chest to place it, it's generally the rib. Wait, no, I've forgotten. It's inferior, superior to the rib. Hold on.
Superior to the rib underneath. Yeah.
Yes. Yeah.
Yeah. There is more subtlety to it. Like sometimes you're going to want to avoid certain structures like the liver. Sometimes it can build up and press, but you'll learn about that more a bit later. That's a bit much for now. All you need to know is that it collects in that cavity. Thanks so much, Lakni, again. That was great. If anyone has any questions, just hit her up during the Zoom meeting. If you don't mind sticking around for 1 or 2 minutes, Lakni. Okay, great.
Yeah, sure
So,
thing.
Alan, I believe you're here. Is there a specific location to insert a chest tube or needle? Do you want to ask that, Lakni, or should I? Is there a specific location to insert a chest tube or needle?
In terms of
Pleural effusion. And I guess any sort of Lakni's frozen a bit. That's really lucky. So it's a good question. It really depends on the type of pathology. So if you have a pneumothorax, which is an air collection, air rises to the top. So you're actually going to insert it in about the second intercostal area. In regards to chest tube, I think they do it in the Lakni, correct me if I'm wrong, in the fifth intercostal area. But
yeah, I think it was the fifth.
That's in regards, it's a safety error. It's because it's protected by the lats and it's over the liver, and it's a bit complicated. We'll do that a bit later in the SEM, I believe, go over that in more detail, but it's a good question. It's called the safety zone. What confused me a lot was that pneumothorax treatment was different to fluid treatment. It's just because air rises to the top. Alan, I believe you're here, so if you don't mind introducing yourself.
Yes, hi guys, my name is Alan and I'm currently a third year medical student. I'm having my placement in the Frankston Hospital, so nice to meet you guys. And I might just be turning off the camera a little bit because like I'm living in the residential village and the internet here is not so good, to be honest, but I'll just start sharing my screen. Sorry, could you please, I think it's disabled. Sorry, David.
Yeah, I'll just make you co-host. One second.
Thank you.
Make co-host. Yes.
Thanks. Sorry guys, actually I should like merge my PowerPoint into the group one, but I haven't done. So I'll just probably do it later tonight. Sorry for that, to be honest. Yep, so what I'm going to cover right now is some part of the respiratory physiology. So I'm going to have a chat with you guys about the lung volume, the gas exchange, and the ventilation via perfusion. And I guess Chris will just cover the gas exchange and like something like oxygen and carbon dioxide respiration later on. So let's just start from the lung volume. So we have a lot of terminologies here, and at the start of year 2, I found these terminologies quite confusing. So I'll just go through it one by one. So let's just start from tidal volume. So tidal volume is the air that moves into the lung with each quiet inspiration, typically 500 milligram. So what we are having right now, like we are definitely not doing exercise. So what we are breathing and breathe out right now is our tidal volume, and it's approximately 500 milligrams. And apart from that, when we do exercise, we can deep breathe in and deep breathe out. So respectively, this is our inspiratory reserve volume and expiratory reserve volume. So inspiratory reserve volume just means the air that we can still breathe in after the tidal volume, and the expiratory reserve volume just means the air that can still be breathed out after a normal expirations. So if we just do deep breath in and deep breath out, we are just using our IRV and ERV. And apart from that, we have the residual volume, which means there's still like certain amount of air which will trap in the lung after maximal expiration. So your lung will not necessarily to collapse after your breath, so you will still have a certain volume, and this volume is our residual volume. So this residual volume does not include in gas exchange, which we will explain a little bit later on. So for the lung volumes, we have a kind of like acronym called LITER. So L is the lung volume, and ITER respectively is the inspiratory reserve volume, tidal volume, expiratory reserve volume, and residual volume. And yeah, I found this like to be a quite good acronym, so it just helped me to clarify a lot of things when I first started learning that. And apart from the lung volume, we have the lung capacities as well, and these are just different terminologies. We have something called inspiratory capacities, which by definition means the amount of air we can breathe in a maximal breathing. So using the formula, the inspiratory capacity just equals to the inspiratory reserve volume plus the tidal volume, which is the upper part here, the inspiratory capacity. And similarly, we have something like equivalent to expiratory capacity, but it is called the functional residual capacity. So it means the functional residual capacity is the amount of air which resides in our lung during the apart from the tidal volume, which means it equals to the expiratory. It equals to the. I think I made a mistake here. It's not EV, it's RV. It's residual volume plus expiratory reserve volume. And we have the vital capacity, which means it is the amount of like air during the maximal breathing, which is the IRV plus TV plus ERV. So the vital capacity is something we rely on when we use the spirometry to assess. We have to assess the lung function. We have to know how well your lung is functioning and kind of like how many air you can breathe in and breathe out during one breath. So that's the vital capacity we are assessing on. And apart from that, we have the total lung capacity, which by definition is kind of like equivalent to the total lung volume. So which means we have the IRV, we have the tidal volume, we have the expiratory reserve volume, and we have the residual volume. So we simply just add these components together and we have the total lung capacity, which is the total volume of the lung. And we have something called dead space, and dead space is definitely a very interesting and very important definition. So dead space, we have two different categories of dead space. The first one is called anatomical dead space. So the anatomical dead space is basically the volume of the conducting airways, which means this just includes your nasal cavity, your pharynx and your larynx and your trachea, just like, because like these tubules are hollow and have some volume, and these volumes are definitely not involved in gas exchange. So we call these volumes as anatomical dead space. And anatomical dead space is approximately about 150 milliliters. And apart from that, we have the physiological dead space, which is a functional measurement of the volume of lungs that does not participate in gas exchange. So let's just think a normal patient, maybe just like what I am doing here. I reckon I have a normal lung function. So my physiological dead space is close to 150 milliliters as well, which is similar to what I had for my anatomical dead space. But in patients with some kind of like pulmonary issues, like I guess our friends were mentioned later on, for example, like asthma or COPD or fibrosis or pulmonary embolism, their functional lung components is kind of like reduced due to some pathological changes. Therefore, they will have an increased physiological dead space afterwards. And I have a little diagram on the top left here. So the region which I highlighted with the red box is the anatomical dead space, which I referred to, which is kind of like the nasal cavity, pharynx, larynx, the trachea, pulmonary bronchi. So these things are anatomical dead space, and because they are not involved in the exchange of gas. Yeah, and I guess we have to do some math to kind of like calculate what it is. So there are several like kind of like signs here. We've got the VD, which stands for the physiological dead space. We have the VT, which is the tidal volume, and P capital A CO2, which is our arterial PCO2. And we have P capitalized E CO2, which is the expired air PCO2. So how do we calculate the physiological dead space? So the physiological dead space, by definition, is the anatomical dead space of the conducting airways plus the alveolar dead space. So approximately the major component of the alveolar dead space just came from the apex of the healthy lung, since kind of like you didn't get much blood supply due to your gravity. So kind of like your blood is more gonna move to the base of your lung, but not the apex of lung due to the effect of gravity. So you don't have that much supply there. Even though you have the gas, like the oxygen and carbon dioxide being there, you don't have like as much a efficient exchange there. So at the apex of the healthy lung has the greatest contribution to our alveolar dead space. And the formula here is the physiological dead space equals to the tidal volumes times the difference of arterial and expired air PCO2 over the arterial PCO2. I think this is a relatively useful formula, even though I don't think it's kind of like being assessed a lot in the end of year exam, but I just guess it's relevant to know about it. Yeah. So yes, this is the apex of the lung we are referring to, and I guess later on in my when I talked about the ventilation and perfusion, I will just cover more about it. Yeah, so this is just a summary diagram about lung volumes and lung capacities. I guess this diagrams like it's kind of like better because like it helped me summarize what it is, and it just give me a relatively clear explanation about kind of like the mechanism behind. And so how do we measure these stuff? We can definitely use the formula to measure the physiological gas space, but in terms of all the stuff before, like the tidal volume, the inspiratory reserve volume, the expiratory reserve volume, and residual volume, we're going to use a spirometry to measure that. But before we start, I would like to emphasize that we cannot measure residual volume using a spirometry. The only thing we can do is to measure the tidal volume, the kind of like total vital capacity, and kind of the IRV and ERV. So spirometry is a device used to assess how well your lung works by measuring how much air you inhale, how much you exhale, and how quickly you exhale. And there's just a diagram showing like how a spirometer may just be look like. And there are several terminologies we might need to get familiar with about the spirometry. So the first one is called forced vital capacity. Since it's called forced, so it just means you have to breathe, kind of like you are going to have the maximal breathe in and breathe out. So the total volume of air that can be exhaled during a maximal force exertion effort was defined as the forced vital capacity. And we've got a FEV1. The little one there just means for the first second. So FEV1 just means the forced expiratory volume during the first second of your expiration. And we have the ratio of FEV1 over FVC. So for normal people like us, we will normally have a FEV1 over FVC ratio about like 75 to 80%. I'm probably more leaning to 80%. So if you have a very reduced FEV1 over FVC ratio, which means your ability to breathe out is limited. So that may just indicate some form of obstruction in your airway, so you can't breathe out. And in some cases, you can also have increased FEV1 over FEC ratio. That's not because you're kind of like breathing much harder than you should be. That's just because your forced vital capacity decreases. So in diseases like much more like a restrictive one, such as fibrosis or emphysema, you guys will get familiar with these kind of like terminologies later on. So you do have a reduced total lung capacity or forced vital capacity, even though you don't have any problem to breathe out, but the FEV1 or FEV1 over FVC ratio can still be increased since the denominator is increased. Sorry, it's decreased. Yeah. So in obstructive lung disease, So in obstructive lung diseases, as I said, asthma, you have your full vital capacity decrease and your FEV1 over FVC decreased as well. But in restrictive lung diseases such as fibrosis and emphysema, your full vital capacity is decreased, but your ability to breathe out does not impair. So your FEV1 over FVC ratio can be normal or increase. So we have a diagram below to illustrate what's going on. So we can clearly see the y-axis of this diagram is the volume of the lung. By all means, it's like we are more kind of like looking at a forced vital capacity. And we can see in both asthma and fibrosis, our forced vital capacity just decreases, which means our lung just kind of like have some limitations to breathing and or like to expand. And we also can record the FEV1 for both asthma and fibrosis. And it's clear, like in patients with fibrosis, the FEV1, the function is not quite impaired because like they still kind of like breathing about like 90% or 80% of the air during the 1 second. That's just because they didn't have much air to breathe out. So the volume just decreases, but the percentage remains like constant or even slightly increased if kind of like we lost a lot of lots of capacity here. But in asthma, since we cannot breathe out, so there's certain obstruction maybe in our airways or maybe in our bronchi, so we just can't breathe out. So we have a reduced forced expiratory volume in the first second. FEV1 is decreased. Yep. Yeah, so this is a summary table. So if we have a restrictive defect, we've got problem with inhaling the gas. So what we check is the FEV1 and FVC, they are both decreasing, but the ratio would probably be the same or slightly increasing. And this may indicate fibrosis, scoliosis, tuberculosis, interstitial disease, and emphysema. And for obstructive, sorry, not emphysema, just for obesity. For obstructive defects, the problem lies here is the difficulty exhaling, so we cannot breathe out. So it just means we have a narrow down airways or have some problems with the flow of the air. So some possible causes may include thickened muscular layer, mucus, and inflammation in the epithelium. So we need to also check FEV1 and FVC. So in this case, FEV1 decreases more than FVC. So for the overall ratio, the ratio will decrease as well. So since I mentioned before, we cannot measure residual volume using a spirometry. So there's an alternative test called helium dilution method. So if you guys did physics in your year 12, I guess you'll be quite familiar with this gas formula. So like if we have two gas samples and kind of like have the other one diluted, we still have the concentration times volume, which equals to the like overall amount of the gas. So we have C1V1 equals to C2V2. So we just use a gas that is insoluble in blood, and we measure the concentration before when we place the helium in the spirometer, and we let the patient inhale the gas and kind of like inhale, exhale, and exhale, and the helium concentration in the lungs will equalize after that, and we can just calculate the concentration later on, and the volume changes later on. And so simply like the V2 minus V1 minus the kind of like the vital volume here is the residual volume. Yep, so gas exchange is my next topic. So let's just start from looking at the Dalton's laws of partial pressures. I guess some of you may just cover that before in chemistry. So the partial pressure equals to the total pressure times the fractional gas concentration. So in the dry inspired air, which we are kind of like inhaling right now, the PO2 is about 160 millimeter Hg. So we know the like atmospheric pressure is 760, and oxygen just kind of like composed of the 21% of the total gas here. So we just use 760 times by 0.21 or 21%, and we get the 160 millimeter mercury. But in humidified tracheal air, the calculation is modified as it is humidified by means we have some water gas or H2O gaseous water in our trachea as well. And this kind of like component also contributes to our atmospheric pressure. So we have to kind of like reduce that part, and after the modification, our PO2 in the trachea is approximately 150 millimeter mercury instead of 160. And we have a table here, just kind of like talking about the diffusion rates depends on the partial pressure differences. So the PO2 in the dry inspired air is 160, and we assume the air we breathe in does not include any carbon dioxide. So we do not have any carbon dioxide in the trachea as well. And the humidified tracheal air is about 150 because there's an addition of water which decreased the PO2. But in alveolar, the number may be just reduced to 100, and I guess these numbers are very important to remember. We have to know the PO2 in alveolar air is 100. In systemic arterial blood should be 100, but in real life cases, it might be a little bit less than 100, and I will explain why later on. And in the vein where the blood is like most deoxygenated, the PO2 is about 40. And for carbon dioxide, it's the same case. In alveolar air, it's about 40, whereas because like 40 is the kind of like the lowest, because like most of the carbon dioxide have been diffused out during that. And when it goes to the arteries, it still remains 40, and in the vein, where it's kind of like most carbon dioxide will kind of like diffuse from the tissue to the vessel, so it could be higher, but about like 46 is a good number. So what I said before is like in real life cases, the systemic arterial blood, PO2 will be a little bit lower than the alveolar air, and this is due to something called the physiological shunt. So that means about 2 or 3% of the blood will bypass the lung from the heart and directly pours into the arterial kind of circulation. So you kind of have a mixture of both the oxygenated blood and deoxygenated blood directly from the heart. So the number could be a little bit less than 100, but kind of like theoretically, if there is perfect equilibrium between the alveolar air and the systemic arterial blood, so if there's perfect equilibrium, we are expect to see like both PO2 to be 100 or the same. Yep. And now I'm going to start to have a chat about ventilation and perfusion. So let's just start from ventilation. So we have two definitions here. The first one is the minute ventilation, just ventilation you do, how many gas you kind of like inspire and expire during 1 minute. So we just use the tidal volume to times the respiratory rate. We can easily get the minute ventilation. But minute ventilation is different with alveolar ventilation because we mentioned the gas space before. So not all the gas we inspired in is used in gas exchange. There are some gas kind of like stay in our trachea. Maybe there are some gas not participating in the gas exchange, and that's our gas space. And the gas space is calculated using the formula I give here. And in terms of calculating the alveolar ventilation, we use the tidal volume and minus the gas space. So this is the actual functional component of the lung we are looking at. And we use that to times the respiratory rate, and we will get alveolar ventilation. Yep, and we've got the Fick's law. So Fick's law is more kind of like relevant to the diffusion here. So for the Fick's law, there are several factors kind of like relevant to the diffusion of the gas. So we need to think about the surface area of the alveoli. Is it a big one or a small one? We have to think about the thickness. So if the kind of like if the alveolar or maybe the endosome has a very thickened membrane, kind of like the efficiency of diffusion will also decrease. And diffusion constant is relatively stay same in all the cases. So probably there's nothing we can do to change that, especially in like a human condition. We always have the same diffusion constant no matter what kind of like underlying pathologies we have. And we have the pressure difference. And this is how we kind of like apply our treatment to get better oxygen diffusion. For example, like in the oxygen therapy, we tend to give like have a increased pressure difference, so the patient might just have better oxygen diffusion afterwards, and this may help kind of like relieve their hypoxic state. So there are some certain pathologies which can change the area, thickness, and pressure difference here. So for the area, if you have emphysema or pulmonary embolism, you may just have less surface area which is capable for diffusion, especially for pulmonary embolism. If you've got an emboli here and you don't have any perfusion across this region, so this area is totally kind of like not involved in your kind of like gas exchange, so you have a decreased area. And in terms of sickness, if you have fibrosis, like if you have massive kind of like fibrins, connective tissue kind of like underlie, so you may just have a thicker membrane for the gas to pass through, which will definitely results in not efficient diffusion. And also we have got pulmonary edema, which means we've got the fluids in the lung, so we'll also kind of like reduce diffusion capacity. And there are some tools we can use to measure the ventilation. The most kind of like convenient one is our oximeter. So you simply just put it on your fingers, and maybe for young adults like us, we are looking for maybe 98 to even 100% when we are not exercised. But the normal value can also range from 93% to 97%. And it is a red flag if the patient has low 90s when they are on oxygen. This is because I guess like Chris will cover the oxygen hemoglobin dissociation curve later on. So when it falls below 90%, the saturation of oxygen will fall quickly after 90%. So even though you only have a small change in your oxygen pressure, you can have a massive change in your saturations. So that means your body tissue can get hypoxic very soon, even though you just got a slightly change in your oxygen level. And there are still lab tests and blood tests we can do to measure the ventilation perfusion, and it is called the arterial blood gas. And for normal arterial blood gas, we're aiming for 100 milligram mercury for oxygen and 40 milligram mercury for carbon dioxide. And we can also use something called DLCO, which is the diffusion capacity for carbon monoxide, to measure ventilation as well. And for pulmonary, so we are just talked about ventilation, which is the air we breathe in, and now we're just gonna cover more about pulmonary circulation, which is the blood supply. So for the pulmonary circulation, it has a much lower pressure. So it's about like 14 or 15 millimeter mercury breath. With our kind of like systemic circulation, it can be like 100, 110, 112, 120. So the pressure in the pulmonary circulation is much lower than what we expect in the systemic circulation. And similarly, the resistance is much lower because we want the blood to flow in. And like in normal patients, especially after they were born, when we take our first breath, the pulmonary blood flow just equals to the right ventricular cardiac output. Yeah, and distribution of the blood flow. So when we lie down or when we lie supine, the blood flow is nearly uniform throughout the lung. So there's kind of like similar blood supply in the apex and in the base. But when we stand upwards, blood is unevenly distributed due to the effect of gravity. So we are supposed to have more blood supplies at the base of the lung, just the lower portion, and maybe less blood supply at the apex of the lung, because it takes a little bit harder for the blood to go that high. And so we have kind of like three different zones here, which is zone 1, zone 2, and zone 3. So zone 1 is the apex of the lung, zone 2 is the region in the middle, and zone 3 is the base. And we'll come back to this diagram later on. So for zone 1, it has the lowest blood flow, zone 2 has the medium blood flow, zone 3 has the highest. And during these three regions, there's also a difference in the blood pressure. So for zone 1, the alveolar pressure is greater than the arterial and greater than the venous. I mean, arterial pressure is always greater than the venous pressure. But in zone 2, as we moving downwards, there are more blood supplying here. So the arterial pressure just kind of like becomes greater. So it's greater than the alveolar right now, and it's still greater than the venous. And at zone 3, the venous pressure can also kind of like goes greater than the alveolar pressure. So in terms of the VQ ratio, so V stands for the ventilation, which means how many air is here. The Q is the perfusion, which means how many blood is here. Things like it's kind of like hard to understand at the start, because like at the apex of the lung, we don't have that much perfusion, we don't have that much blood. And at the base of the lung, we have a lot of blood. So what we expect here is that at the base of the lung, since we have much blood and lots of air there, I mean, I'll just come back. I'll just try to explain it better. So like for ventilation and perfusion, the pattern is the same. So for the apex of the lung, it doesn't have that much air and it doesn't have that much blood. For the base of the lung, it has a lot of air and a lot of blood. But since the regional differences of air is not that relevant here, So kind of like what I would like to say, maybe let's just assume at the base of lung, the PO2 is 100, and maybe at the apex of the lung, the PO2 is only 90. So that didn't have much a difference. But for the perfusion, this could have a like significant change. So in terms of the VQ ratio, even though we have a decrease in ventilation and decrease in perfusion in the apex of the lung, since the decrease in perfusion is more significant than the decrease in ventilation, the VQ ratio is still increases. So we reckon in zone 1, we have a wasted ventilation. But in zone 3, since we have a lot of gas and a lot of perfusion there, but the changing blood supplies is more significant compared with the increase in gas. So we have an overall reduction in the VQ ratio, which is about 0.6. So for normal, like healthy lung, we are aiming for 0.8. It's a perfectly fine ventilation perfusion ratio. And for 0.6, which is lower than 0.8, we believe there is wasted perfusion, by all means too many blood flow comes in here and there's not so many gas to be equilibrated. And there's some definition called hypoxic vasoconstriction, and I personally reckon this is one of the most high-yield stuff in respiratory physiology. So in normal tissue, if you got hypoxia, you will have vasodilation because we wanted to save this tissue, we want to save this cell, and we want to distribute more blood flow to these hypoxic tissues. But in lungs, this is a totally opposite mechanism, as hypoxia will cause vasoconstriction. This is because vasoconstriction will redirect the blood from poorly ventilated hypoxic regions towards the well-ventilated regions. So after that, if we redirect the blood to a well-ventilated regions, we'll have a better efficiency in the gas exchange. So that's why we have hypoxic vasoconstriction. So everything is for having a better ventilation perfusion. Everything doing here is just ensure we can have more oxygen delivered into the blood. So as long as like these bloods gonna circulate across the pulmonary, we want it to be at somewhere with great oxygen supply. So for fetal pulmonary vascular resistance, it's relatively very high since like we don't have any like oxygen in the alveolar before we took the first breath. So during that time, the pulmonary vascular resistance is high. So we don't want any blood to get into our lungs. But as soon as after birth, we have the same kind of like breathing, our alveolar starts to begin oxygenated. And after that, the resistance just dropped significantly. So the lung just starting to work and pump, and the heart just started to pump, like the right ventricle started to have blood in our lungs, and the total like function of lungs starts to work. Yeah, and the VQ defects, and as we talked before, the normal VQ ratio equals to about 80%. Since blood and air are distributed unevenly in lungs, so blood flow is the lowest in zone 1, highest in zone 3. Due to gravity, and ventilation is lower in zone 1, high in zone 3 as well. But the regional differences for ventilation are not as great. So we have got a higher VQ ratio at the apex and lower VQ ratio at the base. So we have more efficient gas exchange at the apex and the base, but I will probably doubt on that. Yeah, so for the VQ mismatch, so if we have for example, like a VQ ratio, which is lesser than 0.8, we're just thinking about we have reduced ventilation, so we can like have a reduced VQ ratio. So let's just think, if there's no ventilation, our VQ ratio will be 0. And this is the case with severe airway obstructions. So for example, if you have something kind of like get stuck in your airway, you can't breathe in, and your VQ ratio will be 0. And we can also have a VQ ratio towards infinity or increasing. This is because we have very, very limited perfusion. So the denominator just decreases, which makes the whole kind of like ratio approaches infinity. So this may just be the case where we have the flow obstruction, maybe due to a pulmonary embolism or other kind of like pathological features. So in terms of the PO2 and PCO2, in airway obstructions, since we do not have any ventilation, we will expect to see the PO2 or PCO2 in our vein being equal to what we have in our alveoli. Since we do not have any ventilation there, we do not equilibrate. So that's the same. And in very severe patients, like very hypoxic patients, the arterial PO2 or PCO2 might also stay same to the PO2, PCO2 in the venous region. And if there's any flow obstruction, we would expect the alveolar PO2 or PCO2 be equals to what we have in the air we breathe in. Since there's nothing to equilibrate, there's no blood flow, we wouldn't expect any drop in the PO2 or PCO2 in the alveolar gas. Yep. And there's a diagram kind of like here showing what it is. And I guess for the dotted line here, it's just the PaO2 or PaCO2, which is the gas in the alveolar air, which we would expect to see. And in perfusion limited ones, we don't have that much blood supply. So we have that equilibration there, but what am I going to say? Sorry for that. I'll just get a bit blanking myself. Yeah. What I'm gonna say is like, if we have like diffusion limited ones, we may not equilibration, or we may not equilibrate with the PaO2 since we didn't have that much air coming in. We may just have a partial pressure lie in the between. But as long as we have better oxygen or gas supplies, for example, if we kind of like dilate the bronchus or just remove the thing like get stuck in our trachea, our curve will come back. And that's it. And how do we measure whether it's a perfusion or diffusion limited exchange? So for perfusion limited exchange, we've got a test called N2O, like the dinitrate. I'm not sure how to say. But the thing is like the gas, for perfusion limited exchange, the gas equilibrates early along the length of the pulmonary capillaries. So by the end, when they reach the base of the lung, it has already been equilibrated. So the base of the lung just do not involve in the gas exchange as it has already been done before. So as long as we increase the amount of gas we breathe in, the base of the lung will be involved afterwards. But if that's a diffusion limited exchange, it just means, for example, maybe let's just think about fibrosis. It's just like the thickening of the alveolar membrane. So after that, we don't have that much kind of like diffusion capacity. And similarly to emphysema, we have some kind of like surface areas is not involved in the diffusion. So in terms of a diffusion limited exchange, the gas does not equilibrate when reaching the end of the capillary. So we just need more kind of like functional unit of the lung to be involved to get this one improved. And there's something called VQ scans we can use to assess the ventilation perfusion kind of like status. And this is a normal VQ scan here. So we can see on the diagram, the perfusion ventilation perfectly matches with each other. But in this slide, when we have a pulmonary embolism, on the left one, we can see there's good ventilation, but on the right side of the lung, there's very, very limited perfusion due to the embolism. So if we have an emboli there, there's no blood flow coming in. So we have kind of like a totally very reduced perfusion on the right side of the lung. So we just compare the perfusion and ventilation, and we just kind of like started to realize the problem arises here is the perfusion. And similarly, on the right side of the diagram, we also have a pulmonary embolism VQ scan. So on the left-hand side, we have, just for the ventilation, I think it's quite good. But for perfusion, we can see it's kind of like it's a little bit whitish on the perfusion scan, which means we do not have any plastic lines here. Sorry. Yep, and I think that's the end of my PowerPoint. So do you guys have any questions for me?
Alan, that was great. Thanks so much. That was really comprehensive. I learned a lot as well. I'll just text Chris. Hey, Chris. Yeah, and thanks everyone for sticking through us. I know we're going a bit over, but yeah, Alan, that was really good. Thank you. Yeah, so any questions, just pop it in that FAQ form we have. And otherwise, yeah, Alan, you're free to enjoy the rest of your day. So hey everyone, yeah, it's been intense, but thanks for sticking around. The next presenter only has about 8 to 10 slides. There's not much, so I'll also let him know we've been on for a while, so he'll get through it quite quickly. But yeah, you're doing a great job for just staying. You'll be great next week if you've listened, even if you've picked up like one sentence of this, you'll be great. So Chris is texting me, he's coming now. I'll send him a link. So just a moment. Here it is. Hey, Chris.
Is my camera working?
It is not. You are quite dark.
I'll just go out and log back in.
Okay. The recordings will be uploaded on YouTube. Yeah. As soon as this is finished, I will upload them. And we'll publish the slides as soon as this finishes as well. So you'll have access to those too. Yeah. There we go. Hey, Chris. Hey. So we've been going for about an hour and a half. So yeah, you're up. Everyone's done really well to stick around. So thanks, everyone.
Do you want me to share screen or?
Yeah, that'd be so you can control the pace and everything.
That'd be easy. Just give me 1 sec.
I'm happy to share if you don't have the slides.
No, I got it.
Okay,
You've disabled participant screen sharing.
that should be fixed now.
Okay. Can everyone see that?
Yeah.
Okay. Hi guys, I'm Chris, and I'll be going over transport of gases and control of breathing. Can you guys hear me well? Okay, easy. So these are just some figures of interest. I reckon the ones for your other lectures are more important, so like your atmospheric pressure, stuff like that. But the main thing to note is that your blood contains around 200 milliliters of oxygen per liter, and that's calculated by getting the concentration of hemoglobin as well as how much oxygen it combines with. So transport of oxygen is transported in 2 ways. So remember how we said there's 200 milliliters. So 3 milliliters is dissolved in plasma and red cell cytoplasm, and most of it is bound reversibly to hemoglobin. So the ICU point is when your arterial pressure of oxygen is around 60 millimeters of mercury, and that's around 90% oxygen saturation. However, we really want it to be anything below 92%, you're worried, because if you go below that, your oxygen sats can drop really quickly. Oxygen diffusion in the alveoli, basically all you need to know is that it reaches equilibrium in 0.25 to 0.3 seconds. And even if you exercise when the blood's flowing quicker, there's plenty of time. Oxygen dissociation curve. Now, this is way more important than, this is very important. So the way I like to think about it is if your curve is shifted towards the right, that's when you're exercising. So when you're exercising, you want your oxygen to detach from hemoglobin so that you can supply your tissues. And so for the causes, think of what happens when you exercise. So when you exercise, you'll produce acid, so like lactic acid, so your acidity will increase. Because of increased metabolism, the temperature will also increase, and of course, your carbon dioxide will increase. And also note that 2,3-DPG will also right shift your curve. Left shifted curve is basically the opposite, except you've got two more things. So fetal hemoglobin, so that's HbF, and carbon monoxide. So what happens with carbon monoxide is when it bounds to hemoglobin, oxygen will get attracted to hemoglobin much more. However, it can't detach from hemoglobin. And so you won't supply your tissues with oxygen. Transport of carbon dioxide is a bit more complex. It's transported in three ways. So the first two ways are the same as oxygen, basically. So it's either dissolved in plasma or bound to hemoglobin. However, the majority of carbon dioxide is converted to bicarbonate in red cells and then moves out into plasma. So what I mean by this is basically you produce your CO2, it will diffuse across the membrane into red cells, and then it will combine with water through carbonic anhydrase to form carbonic acid. This will then dissociate into your bicarb and your hydrogen. The bicarb will diffuse out, and in order to maintain electron neutrality, your chloride must go in. So that's known as your chloride shift. And so once it gets to the lungs, the opposite will happen. So bicarb will go back in, combine with hydrogen, and then form carbon dioxide and water, and carbon dioxide will go out into the lungs and out into the atmosphere. So this equation is very important if you haven't learnt it already. It pops up again in like gastrophysiology and acid base. So now on to control of ventilation. So in your brain, you have two main groups, your ventral respiratory group, and think of it like the sinoatrial nodes in your heart, they're pacemaker cells, which sets up the rhythm. And then you have your dorsal respiratory group, which is basically, I think of it as it can modulate the rhythm. So it can either stimulate inspiration or inhibit inspiration. So I think these have been tested in exams, so know them. So other inhibitors of respiration include opioids, trauma, especially to the medulla, and increased pressure on the medulla. So chemical controls, basically they respond to a decrease in O2, PO2 or hypoxia, increase in hydrogen ions or metabolic acidosis, and increases in carbon dioxide. So they're most sensitive to changes in carbon dioxide, and normally your oxygen concentration is actually not that important. However, note that if you have chronic hypercapnia, so in conditions like chronic bronchitis, so that's COPD, your body will adapt to that increased carbon dioxide levels, and so these receptors won't be as sensitive. So what happens is it will only rely on your hypoxia to breathe. And so if you give someone with COPD too much oxygen, you can cause them to stop breathing. And these receptors are located close to but separately from the baroreceptors. So chemical receptors, so these are basically pH receptors. And so you see the same equation again. So it monitors carbon dioxide levels in the cerebrospinal fluid, but it does so indirectly through hydrogen ions because it is a pH receptor. So these respond slowly, but are responsible for 80% of chemical control, and they're located in the medulla. So to put this all together, you have several receptors. So that's your chemoreceptors. So your mechanoreceptors and your stretch receptors are basically what your lung feels. So your brain can tell how stretched your lungs are, and you also have irritant receptors. So they'll send it up to 2 cranial nerves, the glossopharyngeal and vagus, and then these will project information to the medulla respiratory center. So this is just a quick clinical application, so shallow water drowning. So remember that hypercapnia will cause you to want to breathe, whereas hypoxia will make you black out. So we'll go to this graph here. So normally, when you dive, obviously your oxygen levels will go down and your carbon dioxide levels will go up. However, normally, your carbon dioxide levels will hit this trigger point, which is the threshold point, and make you go back to the surface and breathe. So it'll hit this point before oxygen becomes so low that it makes you black out. However, if you dive with hypocapnia, let's say if you hyperventilate before you dive, if you hyperventilate, you'll blow off all your carbon dioxide, as seen with the drop in carbon dioxide levels. It will mean that you black out before you breathe. And so you'll black out underwater and you'll drown. And that's it.
That was great. Thanks so much, Chris. That really explained. Yeah.
Are there any questions? I know that was really quick.
No, it was good. It was short and it covered everything. That's great. Yeah. If anyone has questions, chuck them in the frequently asked question thing, or you can message us as well. Yeah. No, thank you so much for sticking around. Really appreciate it. We know the session was longer. I'll pass the message that we have to try to keep these closer to an hour. But yeah, thanks so much for sticking around, and have a great rest of your day. Thanks as well, Chris.